All right, guys, this week we're going to talk a lot about the different kinds of shock, but I also want you to learn about how the body compensates and how we can recognize signs of that and then signs of decompensation, which includes all the different kinds of shock. All right, so when the body recognizes that it is in a state of shock and there's hypoperfusion throughout the tissues, it has a compensation system that it engages in order to make sure that tissue stays perfused. Um, We have increased ventilations, obviously to get oxygen into the tissues, increased cardiac output so the blood can be carried to those tissues, and then some level of vasoconstriction that increases preload, increases afterload, also increases the ability of the body to deliver that oxygen and blood to the tissues a little more effectively by doing that. It's not necessarily a bad thing to give a slight increase on preload and afterload. So when that compensation mechanism becomes ineffective, when it gets basically exhausted, uh, you have, these are your initial response, your adrenal response, pituitary a little bit, and then the renin-angiotensin system activation. When those become exhausted, we start showing the signs of decompensating shock, and then that terminates with basically an irreversible shock. So if you got a little chart to go down this, we have an initial decrease in blood pressure. The baroreceptors, especially the ones up in the aortic arch, recognize that blood pressure has started to drop. So it engages those compensation mechanisms in order to maintain good circulatory access to the heart and the brain and all the major organs. Stimulation of that sympathetic nervous system automatically kicks in. The body will start to get a little bit thirsty. It wants to take on more fluid. That isn't something we really recognize in the field right away. None of our trauma patients are going to complain they're thirsty, although if there is a long-term drop in blood pressure, they may exhibit that kind of thing. We do see a lot of anxiety, a lot of restlessness. This can actually be mistaken for an uncooperative patient sometimes. Tachycardia occurs when we have that release of epinephrine, norepi into the system, which increases the heart rate, basically increasing the RPM of that pump to get blood out to the tissues more readily. And then again, vasoconstriction can occur, does occur. We get changes in skin signs depending on how bad the shock is. We may initially see some good skin signs, maybe a little bit on the pale side, as the body shunts the blood to the major organs. And then later on, we'll begin to see the extreme skin sign changes. The renin, angiotensin, aldosterone system kicks in. The end result of that is overall vasoconstriction and retention of salt and water into the body and a decrease in urine output for obvious reasons. The body wants to keep the fluid in the body where it belongs so it can keep the blood levels up. We'll get into that in just a little second. And then we have an increase of the ADH secretion, antidiuretic hormone, which even further helps the body to retain water, tells the kidneys to slow it down a little bit. There's also a aldosterone, which tells the body to retain more sodium. So it gets it both ways there. This is essentially how the RAS pathway works, the renin-angiotensin aldosterone pathway. I do want you to be familiar with some parts of this, actually the parts we're going to talk about. If you can remember how the body combats shock, it helps you to understand what's going on and what part of that combating system or timeline we're in, whether we're compensating or decompensating. So we get an initial drop in blood pressure, maybe a drop in sodium too if the body is recognizing we have a sodium decrease. This is going to be detected in the kidneys for the purpose of secreting the hormone renin. That renin then goes into the bloodstream, which starts to trigger the formation of angiotensin 1, which in itself is a weak vasoconstrictor. Then we have an angiotensin converting enzyme, which is produced in the lungs actually, which is also released into the bloodstream. That angiotensin converting enzyme, or ACE, then converts angiotensin 1 into angiotensin 2, which is a very potent vasoconstrictor. So that's going to act upon the arterial vessels peripherally to help constrict them even further to get blood shunted into the core where it belongs. Simultaneously, it's going to signal the posterior pituitary gland to release the antidiuretic hormone, which just does that. It helps the body to retain more fluid. Also going to stimulate the adrenal cortex up there in the adrenal uh, target organs above the kidneys to secrete aldosterone, which is a hormone that tells the body to retain sodium. Remember, sodium and water have that relationship where water is always going to try to follow salt. So if the body is told to retain more salt, the body's going to then vicariously retain more water. So that aldosterone then stimulates the kidneys to retain more sodium. Overall, we get more fluid retained into the system, hopefully, as long as bleeding is controlled. And then that increased blood pressure, increased sodium concentration then tells the kidneys to, okay, go ahead and slow down that secretion of renin. As long as that's going on, and as long as we get that increase in blood pressure, the kidneys should shut down the renin production. If it does not, it'll continue to release renin until that renin supply is basically exhausted. It doesn't have an endless supply of it. And that's when we start decompensating, when this system starts to fail. All right, so talking about compensating versus decompensating and irreversible shock. Nice chart here you can take a look at. I don't need to read it word for word to you, but do take a good look at it. When we are in compensating shock, we should have a normal blood pressure, heart rate should be slightly increased, we're still getting a respiratory rate, but we may have a little bit of delayed cap refill due to that shunting of some of those smaller arterioles out in the peripheral. So that's going to manifest a little bit cool hands and feet, pale mucous membranes, and so on and so forth. Basically, that vasoconstriction is trying to maintain blood flow, but there is some ischemia starting to build up in those less essential areas. Remember, ischemia is that lack of oxygen to the tissue, and that in a prolonged time frame is going to lead to tissue death. As the body starts to decompensate, as we run out of those compensatory hormones and chemicals, you'll start to see a drop in blood pressure. Maybe initially you'll start to see a uptick in the heart rate, and then also an uptick in the respiratory rate. The body is starting to starve and it's being starved actually. The big one here is the buildup of lactic acids in the body from the anaerobic metabolism that has switched over to. This just makes everything else worse. As this increases, everything else gets worse. And then finally, irreversible shock, profound, less than 60 systolic blood pressure, organs are starting to fail, and it's not a happy place for the body. We don't worry per se about the lactate levels, but at this point, I think normal lactate is like 0.5 to 1. Obviously, 8 is not a good place for that body to be. This is a buildup of lactic acid in the body.